I'm going to present this evening a randomized double-blind placebo-controlled study where we utilize cord blood-derived T regulatory cells for individuals intubated with moderate to severe ARDS secondary to COVID infections. This is a very novel study. It's novel in its design and in its endpoints. This trial was based on animal data and on compassionate use data of cord blood-derived T cells in the treatment of COVID-19 pneumonia. The concept is balance. For individuals who are suffering from moderate to severe ARDS from COVID infection is because there's an inflammatory balance. There are too many inflammatory cells producing cytokines and too few anti-inflammatory cells. When one has a normal response to infection or inflammation, there should be an increase in both inflammatory and anti-inflammatory processes that occur simultaneously. But when there is severe imbalance, that's when individuals have severe disease. And again, in COVID pneumonia, there is a severe imbalance because there's not enough anti-inflammatory cytokines. We can replace those cytokines by the cells that produce them, that is, T regulatory cells. One key question would be, why use cord blood-derived T regulatory cells? And the answer to that is threefold. Cord blood-derived T regulatory cells have three very important attributes. The first is they stay lineage specific. Under stress, regulatory T cells could change to other forms of T cells or inflammatory cells, but that does not hold true with cord blood-derived T regulatory cells. And even with bathed in cytokines that promote transformation or inflammation, these cells do not produce those cytokines. The second important point is cord blood-derived T regulatory cells in the setting of dexamethasone retain their anti-inflammatory properties. This is especially important in COVID, where dexamethasone is part of the standard of care. The third most important part of cord blood-derived T regulatory cells is that these cells are not HLA dependent, so they don't require any HLA matching. And that is why we decided on CK-0802 as our cord blood-derived T regulatory cell infusions. The trial schema was also novel. It incorporated parts of phase 1, phase 2, and phase 3 trials. The phase 1, it is a safety trial. There are patients randomized to a placebo. The placebo did contain DMSO for a toxicity trial. There were two different doses of the cord blood T regulatory cells that were infused, a 100 million flat dose and a 300 million flat dose, meaning these were not weight-based. That's very reminiscent of a phase 2 trial. But importantly, it was randomized, placebo-controlled, double-blind. If we go back to the Ebola pandemic, there were lots of research studies done, but very few had randomization or controls. And sadly, during that pandemic, we learned very little. So purposefully, this trial was placebo-controlled. Not only was the design bold, but the endpoints were bold. We had two main endpoints, one safety, of course, and the second was efficacy at day 28. Efficacy was defined as extubated and alive. This 28-day point turns out to be important, and even in the RAPID trial, which was presented here at this conference with anticoagulation for COVID victims, again, a day 28 endpoint was chosen. What we now know is that COVID complications linger on much longer than 28 days, and longer follow-up is required to assess efficacy, and I am going to report that data this afternoon. The statistics, therefore, utilized a regression model, not just univariate analyses. And we looked with Kaplan-Meier curves for overall survival for placebo, 100 million dose, 300 million dose, and for different parameters. And it turns in that simple analysis, using univariate, there were the curves look very similar. But what's very important to know is even though this was double-blind randomized, the patient populations themselves were actually pretty diverse. It turns out the patients randomized to the 300 million dose, while they were a little bit younger, they were a little bit sicker. There was more vasopressor use, they had worse oxygenation, and there was a longer time to first infusion of the therapeutic cells. This being said, in this 45 patient trial, where patients were randomized 15 to placebo containing DMSO, 15 to 100 million cord blood-derived Treg cells infused on days 0, 3, and 7, or the third arm of 300 million cells of cord blood-derived Tregs infused on days 0, 3, and 7, we actually found, incredibly, that there was over a 90% chance for those who were infused 100 million cells per dose actually had a survival advantage. Not only did they have a survival advantage at day 28, but in long-term follow-up, these patients had a survival advantage. So what I'm excited to discuss this afternoon is that this is the first in-human utilization of allogeneic T regulatory cells in the treatment of viral pneumonitis. Not only did we show that it is safe, we actually showed with high probability an overall survival advantage for individuals to receive the product. This is actually in distinction to one of the teaching points from the teaching sessions earlier here at ASH, again using the RAPID trial, where it was thought that any intervention for a patient with pulmonary compromise has to be made before they enter the ICU. Not only were our patients on the ICU, they were all ventilated, most were prone, and all had major organ dysfunction.